So this patient has symptoms in her left leg when she walks. She has severe pain in her calf muscle and in her foot, and she has some pain in her foot at night when she's trying to sleep, which we call rest pain. We know on an ultrasound that was performed before her surgery that she has a severe narrowing behind her knee, and then that's where we're going to be focusing. Now, the difference with this case versus many of the other cases is that her kidney function is not the best. So we want to try and limit the amount of dye that we use, which can cause problems with the kidneys. So today we're going to use carbon dioxide. That will allow us to see the inside of the arteries and navigate where we need to go. And also we'll probably use ultrasound, which is called intravascular ultrasound, which is an ultrasound probe inside the artery looking out, which gives us a better perspective of how narrow an artery is and the location of the narrowings, and also can be used to try and determine whether the intervention that we do is adequate or maybe something additional needs to be done. So we're going to get started by doing what we call an abdominal aortogram with carbon dioxide. Okay, good. And now we're going to use that as what we call a road map so that I can get the wire into the artery going down the left leg. Road map allows us to see, based on an image that we just took, where the arteries are so that we can navigate our catheters where we need to put them. And it also allows us to use much less contrast when we do these procedures so that we don't have to keep using or injecting dye. So we have the catheter flipped over to the other leg, and we're going to follow that wire down. And you can see the wire there moving down the patient's leg. Water from my hands, please. Okay, good. And in a minute we're going to get a catheter and put it down into the left leg and take some pictures to see where the blockages may be causing her symptoms. The images that you get from carbon dioxide, live please, are not always as good as the images you get from dye. And therefore we tend to use dye. The images are much better. When we do carbon dioxide below the knee, the images that we have aren't really all that clear, and you kind of lose the benefits of carbon dioxide below the knee. Do a shot here. And there you can see a nice image. The top part of the artery where it splits is wide open, which is what we like to see. You can see the artery coming down splits in two. One of those is called the profunda femoris, or the deep femoral artery, and the other one is the superficial femoral artery. We're going to go after the superficial femoral artery and look at that in a little bit more detail. Go live, please. Right now we're going to get a wire down there. Okay. And we can still use carbon dioxide because we're looking at a bigger vessel above the groin, above the knee, and we should be able to see it adequately enough to get a good image. And you can see there, we can see the artery looks pretty good. Head further south. And you can see at the top of the screen there's a little bit of a narrowing. We'll address that with ultrasound to see if that's significant. Head a little further south for me.
Hold still, don't move. Taking a picture now. Hold still. Doing good. Keep holding still. Doing good.
All right, good. You can see on this image, right in the very middle of the knee area, there's a narrowing there. All right, let's take a little shot there. I'm going to use regular contrast for this. Ready? Okay. Now that was an injection with dye, and you can see the difference in quality of the images. You can see also the severe narrowing there right in the middle of the screen. So what we're going to do is get a wire across that. We're going to shave it with a laser. We're going to dilate it with a balloon. And then we're going to look at it with ultrasound first before we do any of that so that we can see exactly how big the artery is above and below the narrowing. And that'll give us a better idea of what size balloon to use after we're done shaving it. Go live. So now we're going to take a look at the artery going down the leg, and we'll get into this is the superficial femoral artery, and I can tell by the size of it. You can tell by the white shadowing on the outside where the vessel wall is, and the red flash is actually blood flow inside the artery. Can you fluoro for me, please? Now we're going to use the X-ray to go down and look at the area that we're working on right now. And now you can see the probe coming in at the top of the screen in an area right there where there's relatively normal caliber vessel, and you'll see it changes diameter here and there. What we're looking for specifically is narrowing in diameter. So here is a relatively normal vessel diameter, which is about 4.5, 5 millimeters. Can you freeze that and measure the size of that vessel for me, please? Keep going, keep going, keep going, right there. So it's about a 6 millimeter vessel. Okay, go live now. And now you'll see on the ultrasound as we advance it through the narrowing, that there's a pretty severe narrowing. You see how little red blood flow there is around that vessel? There's a lot of shadowing inside the artery. You can turn that off. And if you could measure, we'll show you where to use the markers, the inside of the artery there, right there. So we have about a 2 millimeter lumen there, which is a marked difference between 6 and 2. Go live again and turn the IVUS on also. Now interestingly, you don't see any red blood flow in the vessel below this, and that's because the catheter itself is occluding the inside of the artery. You do see it above the narrowing, but when the catheter passes through there, it blocks the blood flow distally, and you don't see any red blood flow distally. Measure the lumen there. A little bit more right there. So it's about 5 millimeters below. So what we're going to do, what we call a pullback. And we're going to look at the vessel going up to see if there's any other narrowings anywhere. Fluoro for me. If you could chase the probe up, please. There's a little bit of narrowing in the mid portion of the artery that we may address. And now we're going to be going into the sheath in just a minute. That's the common femoral artery there. You can see that's nice and wide open. And now you can see we're in the sheath. Okay. So we can see that the narrowing is right at the bottom of the patella, which is a kneecap. And we'll use that as a reference so that we don't have to inject any more contrast to see the blood vessel. Once we treat this area, we'll shoot some contrast a little further down the leg to see if there's any more blockages below the knee. But the ultrasound that she had performed before the procedure didn't really show anything major below the knee. Most of the disease was above the knee. And this was the most critical issue right here. So we'll address this now. And so far we've used a total of 2 cc's of contrast. Now we're going to get our laser open. Now we're going to calibrate the laser, which we have to do every time. Now we're going to advance the laser down the patient's leg. Pull the wire back an inch or two. Okay. And we're going to use the bottom of the kneecap or the patella as our mark so that we don't have to use any more contrast to decide exactly where the artery narrowing is. And it should be right about there. Ready? Pulse. And we'll do several passes here. Five. All right, let's go up a little bit. 60, 60. Now I'm going to increase the power on the laser.
60, 60.
Go live. And we advance the laser roughly 2 millimeters per second. Live, please. Live, please. So we're going to take a quick picture here with a little bit of dye since we'll get a better image. Okay, good. I don't see any issues there. We're going to touch this up. You can see that the opening is a little bit wider now after using the laser. So we're going to take this catheter out, leaving the wire in place, and then we're going to dilate this with a balloon. We use laser primarily for cost. It's very cost effective at what it does. It does tend to remove plaque from the wall of the artery by heating the plaque, and it causes the plaque to vaporize. And there's very low incidence of what we call embolization, which is where plaque breaks off and travels lower down in the leg and blocks off vessels, which can be a real issue. The laser is just as effective as any other atherectomy device to remove plaque. And we always touch up an artery, make it look pretty, if you will, after atherectomy with a balloon. The results of the two combined tend to be better than either one of them alone. So we almost always do both in a patient at the same time, with rare exception. So now we're going to dilate the artery with a balloon. This particular type of balloon is has a smaller shaft, and it goes through the sheath easier. And you can see the two dots approaching the area in question. And we'll just use that as a marker. We'll inflate the balloon, leave it inflated for about a minute. Go live. Okay. And we'll time that. Standard, typical inflation times that we use are anywhere from 30 seconds to a minute. A lot of times the laser will make the picture look funny, so I do like to use a balloon to kind of shape the artery so that the plaque doesn't fracture and we get a better angiographic result. And to really get a good image and a good idea of exactly how the angioplasty worked and the laser worked, you really do need to use just a little bit of dye. So we'll use a little bit of dye here to take a picture and see what we're dealing with. If it doesn't look good, we'll put a small stent in there. If it looks good, we'll leave it alone. Ready? That actually looks pretty good. Everything looks wide open. I don't think we need to stent that. So what we'll do is take the catheter out and take a look up a little higher to make sure we haven't missed any issues. Okay? And that's pretty. I don't see any significant narrowings there. A little further south. And the rest of the artery looks pretty good as well. I don't see anything severe. There are some scattered narrowings throughout there, but I don't think any of them are significant enough to warrant dilating the vessel, because every time you touch a vessel or dilate a vessel, you run the risk of scar tissue forming inside. So for her, this should take care of the problem, which is pain in her calf when she walks. So now we're going to take the sheath out, put a little closure device in the groin, and that'll be the end of it. Basically, this has a two-tiered collagen plug that sits on top of the artery. Part of the plug adheres to the wall of the artery so that it doesn't move. It adheres to the top part, right where the opening is, where the sheath went into the artery. And the second part of it is more of a collagen plug that expands when it gets moist, so that it tends to seal the opening. So it's a two-tiered system. The plug itself sticks to the wall of the artery and doesn't move. And you can see the balloon coming down to meet the tip of the sheath there. So what we'll do, we always open the side port. Live. We pull them both back together. And that's right about where the sheath and the balloon meet. So we advance the plug and we hold it there for about 30 seconds so that it adheres to the wall of the artery. Well, I think she'll have a pretty good result with this. We did use the laser to remove plaque right behind the knee. The ultrasound that she had before the procedure showed a blockage behind the knee. The ultrasound we used here in the operating room showed that. The CO2 used showed the blockage there, and also a little bit of dye that we used. So with her kidney function being poor, we used very little dye. We used about 10 cc's total, which really wouldn't hurt anybody. And she should have a good lasting result with this.